You are about to be put under anesthesia. Perhaps it is tomorrow, perhaps it is next week. And right now, you are frightened. You want to understand what is truly going to happen to you, not the polished version they hand you during the preoperative visit. The real story. What actually takes place inside your brain, your body, your awareness when they send you under. And I'm going to walk you through every bit of it, because you have a right to know. My name is Dr. Dan Carter. Over the course of my career, I have watched this process play out thousands of times. I have seen people lose consciousness in a matter of seconds and resurface hours later with no recollection of anything in between. I have seen everything go flawlessly, and I have seen things go sideways. What I am about to share is what genuinely happens inside that operating room. The science, the hazards, the things the medical team does not always lay out for you because they would rather not add to your fear. But you are here because you want the unvarnished truth. So let us get into it. The question everyone thinks but nobody wants to ask. Will I wake up in the middle of surgery? It is called anesthesia awareness, and yes, it is a real phenomenon. But before panic sets in, let me give you the actual figures. It occurs in roughly 1 to 2 cases out of every 1,000. That is 0.1 to 0.2%. Your lifetime odds of being struck by lightning are higher. But it does occur, and when it does, the experience is deeply traumatic. Patients describe lying paralyzed yet fully conscious, hearing the surgical team talk, feeling physical sensations, unable to signal anyone that they are awake. Safeguards exist to prevent this. Monitors that track brain electrical activity, medications calibrated with great precision. But medicine is not infallible, and you should be aware of that. What actually happens when they put you under? You are lying on the operating table. The surgical lights blaze overhead. The room is cold. It is always cold, because lower temperatures slow bacterial growth. The anesthesiologist is standing beside you. They have introduced themselves. They have reviewed your chart. They know your medical history, your allergies, your anxieties. And they are about to do something that is equal parts miraculous and terrifying. They are going to switch off your consciousness. Sit with that for a moment. Consciousness. The very thing that makes you who you are. The awareness of being alive. They are going to eliminate it chemically. And then, once the surgeons have finished opening your body and repairing whatever needs to be repaired, they are going to bring it back. As though flipping a light off and then on again. Except it is not a light switch. It is a meticulously orchestrated chemical manipulation of your brain. Here is the sequence, step by step. Pre-medication. First comes a sedative, typically something like midazolam, a benzodiazepine. It accomplishes 2 things. It quiets your anxiety. And, this is the part patients find unsettling, it induces anterograde amnesia. You will not retain any memory of what happens after it enters your bloodstream. You might be chatting with the nurses, cracking jokes, signing additional consent forms, and afterward, you will recall none of it. Your brain simply stops laying down new memories. Induction. Next, you are asked to take several deep breaths of pure oxygen. This is called pre-oxygenation. In roughly 60 seconds, you are going to stop breathing on your own, and the anesthesiologist needs your blood loaded with oxygen to buy enough time to secure your airway. You breathe the oxygen, and then propofol is pushed into your IV line. Propofol is white. It looks like milk. Operating room teams sometimes call it milk of amnesia. It stings going in. Patients often say it feels as though their arm is on fire. That is normal. It is not causing any damage. It simply triggers pain receptors as it travels up the vein. But you will not dwell on the sting for long, because within seconds, you are gone. And when I say gone, I mean completely gone. Propofol acts faster than almost any drug in the medical toolkit. 8 to 10 seconds from injection to loss of consciousness. Your eyes roll upward, your body goes slack, your breathing ceases. For all practical purposes, you have entered a state very close to death. Your consciousness has been erased, and now it falls to the anesthesiologist to keep you alive. The mystery we still cannot solve. Here is something that surprises people. We do not actually understand how anesthesia works. We know what it does. We can observe its effects on brain imaging, but the mechanism, the precise process by which these drugs extinguish consciousness, remains unsolved. Theories exist. The leading one holds that the drugs disrupt communication between different regions of the brain. The prefrontal cortex, responsible for awareness and decision-making, gets disconnected from the rest. The brain stops weaving information together into a unified experience, and without that integration, consciousness vanishes. What remains is scattered neural activity going nowhere. Securing the airway. Back to you on the table. You have stopped breathing, so the anesthesiologist is breathing for you. A mask is placed over your face, and a bag is squeezed by hand to force oxygen into your lungs. Your chest rises and falls. The monitors are tracking everything: oxygen saturation, heart rate, blood pressure, all of which begin to shift the moment consciousness is lost. Now the airway needs to be secured for the duration. Manual ventilation cannot continue for an entire surgery. So the anesthesiologist performs intubation. Your mouth is opened. A laryngoscope, essentially a curved metal blade fitted with a light, is used to visualize the vocal cords. A plastic tube is guided down through the trachea into the windpipe. That tube connects to a ventilator, the machine that will breathe for you from this point on. Intubation is a practice skill, honed over years, and it is not always straightforward. Some individuals have challenging airways, anatomy that makes the vocal cords difficult to see. When that happens, contingency plans exist: video laryngoscopes, alternative airway devices, and in extreme circumstances, a surgical opening can be created. But the vast majority of the time, it proceeds smoothly. The tube slides in. A small balloon at its tip is inflated to anchor it in place. Proper positioning is confirmed by listening to both lungs. You are now connected to the ventilator. Paralysis. But you are not merely unconscious, you have also been paralyzed. A neuromuscular blocking agent, typically rocuronium or succinylcholine, has been administered. These drugs sever the signal between your nerves and your muscles. Your brain can fire as many commands as it likes. Your muscles will not respond. This serves two purposes. It makes intubation easier because the jaw and vocal cords relax completely, and it prevents any movement during surgery. Even an unconscious person can exhibit reflexive motions, and that cannot be tolerated when a surgeon is working inside you. So now you are unconscious, paralyzed, and being mechanically ventilated. But the anesthesiologist's work is far from over. Maintaining the anesthetic. Keeping you unconscious demands constant, unbroken attention. What is being delivered is called a balanced anesthetic, usually a blend of inhaled anesthetic gas, such as sevoflurane, and intravenous medications. These are adjusted continuously based on what is happening surgically and how your body is responding. Blood pressure typically falls during surgery. That is expected. Anesthesia causes vasodilation. Your blood vessels relax, blood pools in the extremities, the heart does not have to push as hard, and pressure drops. If it drops too far, vasopressors are given to bring it back up. If the heart rate slows excessively, atropine. If it races, beta blockers. The anesthesiologist is making constant micro-corrections to keep every vital sign within a safe range. And here is something most people do not appreciate. They are not in the operating room multitasking. They are not glancing at a phone or making small talk. Their entire concentration is fixed on you. They are tracking dozens of variables at once: oxygen levels, carbon dioxide levels, ventilation pressures, cardiac rhythm, body temperature, the depth of anesthesia. Listening to your lungs, watching the rise and fall of your chest, checking your pupils, feeling the temperature of your skin. Every one of these data points tells them how you are doing. The surgery continues. The surgeon does their work, and you are somewhere else entirely. Not asleep, not dreaming, simply absent. Research has demonstrated that under a properly maintained anesthetic, the brain does not produce dreams. There is not enough activity for that. You are not asleep in the conventional sense. Normal sleep is an active process. The brain cycles through distinct stages, and dreams arise during REM sleep. Under anesthesia, none of that takes place. Brain activity is suppressed, dampened. There is nothing to recall because nothing is being experienced, unless something goes wrong. On rare occasions, the anesthesia is not deep enough. The patient begins to lighten. There are telltale signs: tearing of the eyes, a climbing heart rate, subtle twitches. If the paralytic has partially worn off, the response is immediate. The anesthetic is deepened. But occasionally, in that narrow window, patients do have experiences. They hear things, they feel things, and because they can neither move nor communicate, it is terrifying. That is anesthesia awareness, and it is precisely why brain monitoring technology exists. EEG-based systems that track the electrical activity in the brain and indicate how deep the anesthesia truly is. The moment that frightens people most, waking up. The surgery is wrapping up, the surgeon is closing, and it is time to bring you back. The anesthetic gases are discontinued, the intravenous medications are tapered. The body is allowed to metabolize what remains in the bloodstream. The drugs begin to clear. Brain activity starts to climb. You are transitioning from that suppressed state back toward consciousness, but you are still paralyzed, still intubated. This is a critical window. You need to regain enough awareness to breathe independently, but the breathing tube cannot come out until your protective airway reflexes have returned. If it is removed too soon, you could aspirate. Stomach contents could enter the lungs. So the anesthesiologist waits, watching for signs of awakening, movement, a response to verbal cues. Squeeze my hand. Open your eyes. Take a deep breath. When those signs appear, when there is confidence that you can safeguard your own airway and breathe adequately, the paralytic is reversed. Sugamidex or neostigmine is administered. These agents counteract the neuromuscular blockade. Your muscles begin responding again. You start breathing on your own. The ventilator is still providing support, but your own respiratory effort is visible. And then the tube is withdrawn. The balloon is deflated. The tube is drawn out of the trachea. You cough. You gag. This is normal. You may not remember it. That is the lingering amnesia from the medications, but it happens. In those first moments after the tube comes out, the anesthesiologist remains at your side, watching closely, making sure you are breathing well, making sure your oxygen levels hold, making sure you are safe. You are conscious now, more or less. You are in what is called emergence, that twilight territory between unconsciousness and full awareness. You may be confused, agitated. Some patients come out swinging and thrashing, a phenomenon known as emergence delirium. Others surface calmly, peacefully. Everyone is different. But you are breathing on your own. Your heart is beating on its own. You have been brought back. You are wheeled into recovery, the PACU, the post-anesthesia care unit. Nurses are monitoring you. You are still receiving supplemental oxygen, still wired to machines tracking blood pressure, heart rate, and oxygen saturation. And gradually, over the next hour or two, you wake up fully. The amnesia fades. You become oriented. You remember your name, where you are, what happened. What no one talks about afterward. What you have just been through was profound. Your consciousness was obliterated. Your body was paralyzed. Your most fundamental life functions, breathing, circulation, were handed over to machines and medications. You were cut open. Your organs were handled. And then you were brought back. You traveled very close to death and returned. And for most people, there is no memory of it whatsoever. Just a blink. One moment you are counting backward, the next you are waking up in recovery. But that absence, that void in your conscious experience, some people find it deeply unsettling. Where were you? What happens to consciousness when it is switched off? Does it go somewhere, or does it simply stop existing? These are philosophical questions as much as medical ones, and nobody can answer them definitively. The brain scans can be interpreted. The neural activity can be quantified. But what happens to you? To your inner experience, to the thing that makes you aware you are alive, that remains a mystery. Some patients report near-death experiences, particularly those who have had complications, cardiac arrest under anesthesia, clinical death. They describe visions, encounters with people who have passed on, an overwhelming sense of peace, moving through corridors of light. Skeptics attribute it to cerebral hypoxia, a lack of oxygen producing hallucinations as the brain shuts down. Others see it as evidence of something beyond the physical. Both viewpoints coexist within the walls of every hospital. I recall hearing about a patient whose heart stopped during what should have been an unremarkable procedure. The team worked on him for close to 7 minutes. Chest compressions, epinephrine, defibrillation. They brought him back. And when he regained consciousness, he told the doctors he had been somewhere else. Somewhere quiet. He said his late grandmother was there. She smiled at him, told him he still had unfinished business, and then he felt himself being drawn back. Was that real? Was it his failing brain assembling comforting images from stored memories? No one can say with certainty, but he was convinced it was real, and it transformed him. He came back different, less fearful, more certain of something he could not quite articulate. Understanding the risks. The dangers of anesthesia are genuine. Death under anesthesia is uncommon but possible, roughly one case in every 200,000 to 300,000. The odds rise if you have significant health problems, heart disease, lung disease, very advanced age. But for otherwise healthy people undergoing routine surgery, the risk is extraordinarily small. You are statistically more likely to die driving to the hospital than from the anesthesia itself. Complications short of death, however, are more frequent. Allergic reactions, breathing difficulties, cardiovascular instability, awareness, postoperative nausea and vomiting, a sore throat from the intubation tube, confusion and disorientation, especially in elderly patients. These things do happen. They are managed. The team is prepared for every one of them, but they are part of the reality of anesthesia. The weight of responsibility. There is a burden that accompanies this work, one that never lifts and never grows lighter. Every case matters. Every patient matters. The anesthesiologist holds your life in their hands for the entire time you are under. A misstep can mean death. A lapse in monitoring can mean a catastrophic complication. People ask whether that kind of responsibility ever becomes frightening, whether doubt ever surfaces. And the honest answer is yes. Not in a way that breeds incompetence, but in a way that breeds vigilance. The day that healthy fear vanishes is the day someone should walk away from the operating room. Because fear, a constructive fear, a profound respect for what is being done, is what keeps patients safe. What I want you to carry into surgery. So when the time comes for you to go under anesthesia, know this. You are being cared for by someone who grasps the full magnitude of what they are doing. Someone who trained for years to handle every conceivable complication. Someone who is going to watch over you with undivided attention for the entire procedure. You are not just another case on the schedule. You are a person, a life, someone's family member, someone's friend. And bringing you safely through surgery and back to consciousness, that is not merely a profession. For the people in that room, it is a calling. The enigma of consciousness, the power to extinguish it and restore it, the responsibility of holding life and death in the balance. That is what happens when you go under anesthesia. And I hope that now, knowing the full picture, you can walk into surgery with less fear. Not because there is no risk, there is, but because you understand what is taking place. Because you know someone is watching over you. Because you know they have done this thousands of times before, and they will bring you back, just as they always do. If you are facing a procedure soon, know that it is perfectly all right to ask questions, to share your fears with your anesthesiologist. They want you to feel as safe as possible, because your trust in them, that is something they never take lightly. I am Dr. Dan Carter. Take care of yourselves. I will see you in the next one.